Hello, I've been asked today to talk about medication safety in aged care, our roles and our responsibilities. I want to cover what I see as our responsibilities with regards to the residents of the aged care facility and also our responsibilities to the facility itself. And I want to start though first by telling you a story. And this story is about my friend Pete. Pete's a 76-year-old former farmer. He's talkative and engaging, but he's been admitted to the aged care facility because of his dementia. He's had increasing trouble with his gait in particular, and he's having trouble showering, dressing himself and getting himself in and out of bed. When he was admitted to the aged care facility, Pete was taking simvastatin and citalopram. Not long after making the aged care residence his home, Pete became incontinent of urine and faeces. And due to the unsteadiness of his feet, the staff were also trying to restrict him to moving about in a wheelchair. The staff were concerned that Pete might be experiencing pain because when they moved him around, his facial expressions suggested that he might have pain. And so a buprenorphine patch was added to his regimen. By January, Pete's gait problems had worsened, and Pete was sometimes grumpy with the staff when they were trying to get him ready for a shower. Diazepam and risperidone were added to his regimen. And by February, a month later, Pete was increasingly affected by jerky limbs, so clonazepam, oral drops, when required, was added. Despite that PRN order, clonazepam was administered each day, sometimes as multiple doses. And over the course of a week, Pete became increasingly incoherent, and by the end of the week, he was non-responsive. Pete's dementia had never affected his ability to talk. He loved to talk, and he was very proud of the fact that he could recite the Jabberwocky, a poem he'd taught himself after he was diagnosed with dementia. Pete's wife was very supportive of Pete. She visited the facility daily, twice a day, sometimes for each meal. She was very concerned and a great advocate on his behalf, and she even voiced concerns that it might be his medicines that were causing the problem. No one called the pharmacist. Pete's medicines continued to be administered. Pete remained non-responsive. 2 weeks later, Pete was admitted to the local hospital, which was 50 kilometres away. He spent 10 days in that hospital and the staff adjusted his medicines. Pete then returned to the facility, his usual talkative self. I think what distresses me about that story is that Pete and his wife experienced a completely predictable adverse medicine event. And the other thing that's interesting about that story is it could have been resolved without the need for Pete to go to hospital. You'll see this picture that I've got on the slide here, which just shows almost exactly Pete's story. The addition of one sedative medicine after another sedative medicine after another sedative medicine, gradually contributing to decline. And then the administration of that PRN medicine, and if it had been used intermittently, maybe we wouldn't have had this problem. But by being used every day, we could predict that that adverse event, because of the half-life of this medicine, would be occurring within 4 or 5 days. And of course, the tragedy that these kind of insults for our frail older residents, causing often permanent loss of capacity and ability. And I think the other thing that for me is sad about this story is that this isn't a story that's unique to Pete. If you haven't seen this picture, this is data from the Registry of Older Australians, and it was published in the Medical Journal of Australia this year. And what you see on the left-hand side of the graph are the proportion of people who were on antipsychotics, benzodiazepines and antidepressants before they went into the aged care facility, up to a year before. What happens in the first 3 months after entering the facility, and what happens across the remainder of the year. What should alarm us about that is the huge rise, really. Antipsychotics almost, well, they treble and almost quadruple. The benzodiazepines double, although then they come down a little bit. and the antidepressants go up, almost doubling. But they don't come down. You might think these medicines might be used temporarily, but they don't come down. What can we do to improve that care? And so here I am thinking that Pete's story and those of every other person like Pete really exemplify our role and responsibilities in aged care. We've got to remember that older people are among one of the groups most vulnerable in society. And of course, we know that older people are the most vulnerable to the adverse consequences of medicines. And so for me, I think our roles and responsibilities are really clear. It's our job to ensure this very vulnerable group avoid preventable harms from medicines, and where we can, achieve the best possible outcomes for them. And I think importantly for that, we need to be present. There was no pharmacist in Pete's story. So where might our starting point be? Well, we need to actually engage with the population that we're looking after. We need to know and understand these people. We need to understand their needs and preferences. And this can't be achieved by chart review alone. I've been working with pharmacists in aged care over the last year or two, and one of the things that's been disturbing is to discover that with the COVID lockdown, for example, some of the pharmacists were allowed in to do medicine review because it was only a chart review. We won't understand values, needs, preferences, and patient deterioration from a chart review. We also need to engage with the facility in which our population live. We need to know and understand the culture of that facility and work with the facility to ensure the cultural practices support quality use of medicines. And I'll come back to that second issue a bit later in this talk. But what might our starting point be? And it's very clear to me, our responsibility front and foremost is patient engagement. Discussion with the patient, their carer, the staff who care for them about changes in the patient's health since starting their medicines or associated with changes in the use of when required medicines. If you didn't talk to the residents, you wouldn't know a story like Barbara's, where Barbara told us that she was most terrified at the sound of the nurses pushing the medication trolley to her room each day. That's an awful thought, isn't it? Why was she scared? Oh, because they crushed up her medicines and they tasted foul. Nobody was listening. Nobody was solving the problem. If you're not sure about discussing with patients and what you might talk about and how you might identify some of these adverse events, it's worth becoming familiar with resources and tools like this, such as the Assessing Medication Effects using Residents Assessment Data. It's a US tool, but it gives us some insight into what are the kinds of things we might be looking for, because we can say to the patients, their carers, the staff, have they been more distracted? Have they been more restless? Have you noticed that you're having more difficulty finding your words? These are ways we can think about highlighting those early evidence of medicine-induced deterioration. And these charts are nice because we can line them up with what are the medicines taking, what are the symptoms we're observing from, or what are the symptoms we're learning about from things people are telling us. We also need to go and review those care records to look in particular for evidence of avoidable harm. Things like falls, things like delirium, fecal impaction, new onset incontinence, weight changes, bruising or bleeding. And again, this tool, it gives us some nice ways of thinking. Here we can list the events that could be evidence of avoidable harm, and here we can list the medicines, and we can start to do these cross-tabulations to understand our stories. If you're not familiar with the ambulatory care sensitive conditions, the list is here. It's things like asthma, cellulitis, congestive heart failure, chronic obstructive pulmonary disease, dehydration, big cause of falls, gastroenteritis, diabetes complications, high blood pressure, pneumonia, urinary tract infection, seizures, and of course injuries from falls and fractures. These conditions are thought to be avoidable with good primary care. And while we haven't got the numbers from Australia, we know from Sweden that 42% of all admissions from nursing homes are for these conditions. And so looking at what did they go to hospital for, were there any of these conditions that they went to hospital for where we've perhaps got underuse of necessary medicines rather than some of the over, although the falls and injuries usually from overuse. And of course, that important context situation that we need to know about, our responsibility to understand context. Because if we don't, we might discover that Harry has swollen legs. We might even realise that Harry's on a calcium channel blocker, and we could make that conclusion. But if we don't know that Harry's been sleeping in his chair for the last 6 months, we might come to the wrong understanding. And why has Harry been sleeping in his chair? Well, he fell out of bed because he thinks his bed's too narrow, but no one's listening to him. No one's getting him a wider bed. And finally, we must remember when we do all of this work, we have a responsibility to remember that risk varies with patient characteristics. The data I'm about to show you, I think we don't do this well enough for you. We don't provide you with information that is relevant to particular patients and their characteristics. We too often provide you with information that is the general population risk of a medicine. But I just wanted to show you how that risk can vary. So in this slide here, we have the number needed to harm if we treat people with non-steroidal anti-inflammatories for 1 year to get one additional hospitalisation that's related to a non-steroidal, such as heart failure, renal failure, gastrointestinal bleed. And what we see is in the general population, you'd have to treat 137 patients for a year to get a hospitalisation, one extra. But if you've got heart failure, it's only 27. And if you've got diabetes, it's only 39. And we can do the same thing with sedative medicines. And this, I think we urgently need to start doing this work. I've calculated this based on the incidence of hip fracture across these different age groups and risk, age-specific risk estimates. And what you find is that the number needed to harm for SSRI antidepressants causing hip fracture at a population level is 340 people. If you're 50 to 60, it's closer to 1900. It comes down to 1300 as you get into 60s. But look what happens when we get down to our 85-year-olds. It's down to 74. The risk difference is quite significant. And of course, that's just for SSRIs. We have to remember that the risk is additive when we have stories like Pete's where we add the opioid and then we add the benzodiazepine and then we add the antipsychotic and then we add another benzodiazepine, we are getting cumulative risk. And if you're not familiar with this work, this is showing you the cumulative risk from anticholinergic medicines for a hospitalisation for a confusion event. And once someone's on 3 anticholinergic medicines, we have a 4-fold increase in that risk of hospitalisation. And you can be sure if we're seeing that risk for hospitalisation, it'll be more prevalent in the community where we've just lost a few words or we're not quite as sharp, we can't remember names quite as quickly as we did. And this same kind of pattern we see for increasing risk of falls. 20% increased risk, 70% increased risk, doubling of risk, 3-fold risk. And finally, that very important thing, and that thing that as the rules have changed around medicines review, we have more opportunity for, our responsibility, active follow-up. Here we have a story about Mary who, the pharmacist had been working with Mary over several visits to try and resolve the issue that was of concern to Mary of blood in her stools. She had to keep advocating on Mary's behalf to get the dose of dabigatran changed. It went on, and eventually the doctor decided, yes, we'll change the dose, even though he didn't think this was the issue. And of course, Mary told the pharmacist this had resolved and she no longer had bruising. It's a great story of our role and our responsibilities in resolving problems by continuing to advocate for people. I think in the year when we've had, or the years when we're having royal commissions into aged care, it's important that we remember that we also have this responsibility to the facility. I'm sure you're all familiar with the Royal Commission report that talked about the shocking tale of neglect. And I think one of the things that we need to remember is that medicine use can and does give us insight into facility-wide problems. And I think it's important to remember that often you are the people who have that facility-wide insight. In days past, when we used to administer medicines, or the nurse used to administer medicines from a collective container, it was very easy for the nurse to know exactly how many residents in the facility were on an antipsychotic or on an antidepressant. And I'm not advocating that we go back to those modes of operation. However, once we've put everything into dose administration as or unit dose packing, and we're just administering them, it's hard for facility staff to get an overview, front of mind, of how many people are on different medicines that might be a problem. And I just wanted to show you these data if you're not familiar with them. The one on the right is Australian data looking at the use of antipsychotics, and each circle represents a different facility, different numbers of beds along the bottom, but the proportion of people in that facility that are on antipsychotics. And while we have median, that's the black line going through the middle, we can see that some facilities have less than 20% of people on, and some facilities have more than 40% of people on. And of course, this is associated with consequences. The data on the left comes from New Zealand, looking at the variation in rates of delirium in aged care, quite likely directly associated with the variation in rates in sedative use, and in particular cumulative or multiple sedative use. If you're not familiar with these data, and this comes from a while ago, we haven't got anything that's more recent, but when looking at medicine use in aged care, 35% of it was when required medicine use. And that study by Julie Stokes and others found that while resident characteristics were some of the reason that we had PRN use, the key determinant was the specific nursing home in which the resident lived. So we have a role in facility-wide medicine use evaluation. We need to create for people an overview of the entire facility records and be thinking about whether or not there might be cultural or organisational practices either promoting appropriate or inappropriate medicine use. Is there frequent and widespread use of psychotropics? Is there frequent use of laxatives or proton pump inhibitors? Or perhaps infrequent use of skin emollients, or long-term and frequent use of topical antifungals? You can't be sure, but these are all potential examples of indicative of perhaps facility-wide issues, the resolution of which will require working in a multidisciplinary team with the facility staff. For example, might we have to talk to both the directors of care and perhaps the activities or mental wellbeing coordinators or exercise coordinators if we're seeing lots of sedative use across the facility? What might we have to talk to the dietitians and meal planners if we're seeing lots of use of medicines to support gastrointestinal conditions? What about our skincare? Might we have to engage with the nurse? I think these are really challenging roles for us because they're not where we've traditionally been. But if we tried to solve these problems by just giving people advice about they shouldn't be used, or lower the dose, or don't use the guidelines, say no, we won't succeed in helping the facility and helping the residents of the facility optimising their medicine use. And we certainly will be contributing to harm. And finally, one particular element of that facility-wide use is our role in chemical restraint. I'm sure, again, this is the issue that's come up in the Aged Care Royal Commission, but the use of both physical and chemical restraint, contentious. Many accounts of physical restraint of residents and, of course, the overuse or misuse of psychotropic and other medication. Chemical restraint, I think it's interesting because it can be intentional, but it can also be accidental. And I think Pete's story is an example of kind of accidental. You could call it overuse, but it's a little bit also perhaps in this chemical restraint. The border is murky. But I think we must remember kind of the complexity of what it is we're trying to deal with when we're talking about people. We usually give things like antipsychotics or antidepressants to help manage someone who's in distress. But distress isn't always biological, and that's what this example is trying to show. We might have clinical reasons, biological reasons and sensations, but maybe distress is associated with our emotions that need another strategy, music therapy or something like that. Or maybe our distress is associated with thoughts where we might need some cognitive tools. And in aged care, then we have all of these other things, the culture of the facility, the number of staff on, our particular staff member on, and other environmental things such as, is the facility built in a way that's easy to get lost or hard to get lost, that make this person in distress complex things to manage. But we have to think, I think, in supporting facilities to minimise chemical restraint in this kind of environment. What might we help the facility think about at a facility-wide level, and not just think about a person's wandering, which shouldn't be used with things like antipsychotics, although perhaps aggression is where the evidence supports their use. It's important to know, if you haven't seen these, that there is no regulation of physical and chemical restraint, and this comes from the June 2020 guidelines. It does talk about the medical practitioner and the nurse practitioner having assessed the people and prescribed the medicine. It does say that the decision has to be documented, and it does say that the consumer or their representative has to be informed. I think what's of note, I searched that whole regulatory bulletin and it doesn't identify a role for pharmacists. And yet, here's our role, particularly in this area of accidental restraint or accidental non-responsiveness. And I'm interested in this space whether or not it's time for us to think about developing new roles, such as a regular review of the PRN administration practices of the facility. Are people getting their PRN medicines administered daily? Are they getting them always at a certain time? Like, is it always happening at shower time? Is it always happening at 7 p.m. straight after tea? Is it always one particular staff member? Are they never getting PRN medicines? And that's one of the other stories that people told us about, how they had all these symptoms and no one offered them anything, even though the PRN medicines were charged. What might happen if we took responsibility for reviewing that and we set up almost a weekly or fortnightly case conference to review these cases of delirium, cases of non-responsiveness, cases of continued administration of sedative medicines? If we reviewed those with the senior nurse, could we develop plans for resolution for the resident? Could we develop plans around staff education about half-lives? Because let's imagine what it looks like for a staff member. I administered the medicine to Pete yesterday, it was fine. Had it the day before, he was fine. Had it the day before, he was fine. They may not associate that day 4 and 5 when he starts to get a bit dopey is because of something they've been now doing continually for 5 days. I think there's a critical role here for us. So therein lies our roles and responsibilities. We have a role in patients and a responsibility of patients, a role for the facility-wide practices, and a particular role looking, I think, at chemical restraint. And so I think, to conclude, it is our role and our responsibility to develop relationships, to build trust, to journey together and to stop avoidable harms. And somewhere in this presentation I was talking about Harry, who was too scared. He was sleeping in the chair, too scared to get out of his bed. It was a pharmacist who was able to resolve Harry's story. She heard his concern and she told Harry she was concerned about him, and she talked to the staff about the issue of his bed, and she encouraged him to get out of the room. Of course, she built this trust up over 3 or 4 visits. Harry, he's now doing exercises by himself. He's bought himself a new recliner, and he's even going for walks down the corridor. The new bed's on order. Thank you very much.